Today we have 3 live cases, one from UK, and also we have 2 live transmission from Ain Shams Cardiology Department, Cath Lab. So it'll be one at 2 o'clock, and I think the other one will be 4. And we have some good lectures on retrograde and antigrade wire escalation and tips and tricks. Yeah, Muhannad, do you hear us? Hello, Muhannad.
Okay, good morning. Can you hear me?
Good morning, Muhannad.
Good morning. Can you hear me okay?
Yeah, we have Dr. Muhannad Egrid from Newcastle. He's one of the experts in CTO PCI. Welcome you virtually in Egypt. So we welcome all your Cath Lab team. Thank you.
Okay, good morning. And
good
welcome
morning,
to
Muhannad,
Newcastle.
and congratulations for the full professor job.
Thank you very much. Yes, it's been a couple of months after a long wait, but there we go. Thank you for the invitation and for the opportunity, guys, to present to you. I have the team with me here. Mohammed Fag, he's one of your production. He's from Egypt, and he was my fellow complex and CTO fellow last year, but he's a consultant working in our center right now. And we have Tariq Salim, who's also my new CTO and complex fellow. And we have the team here, April, Rebecca, and David, and Sandra outside. So we have a case for you that I chose because it's a subject that we published about, and I've been promoting the message. And I'm going to let, actually, we could put the slides on just to give you the background on this patient, and we can discuss what the plan is. Can you see the slides?
Yeah, we can see it clearly.
Yeah, so this was a 55-year-old lady, had a previous anterior MI in 2013 with a stent, and then further PCI to in-stent restenosis in 2014. And the reason for that, I think, was an undersized, underexpanded stent. Then she comes back with another event and was referred for surgery. She had a lima to LAD and vein graft to the left posterior branch and a vein graft to the OM. She has a history of insulin-dependent diabetes, COPD, and previous CVA. And she was admitted to us in September, where the vein graft to the right coronary artery, i.e. to the LV branch, was completely blocked. She had a normal LV function. And at the time, I was asked about this lady, and basically we said we could open the vein graft, and the vein graft to the right coronary artery was open with a stent in. But of course, this is where the discussion comes in. How many people would accept that you open the vein graft and leave it? And depending on the symptoms, or how many would say, okay, this is an acute event, we treated it, but we know the vein graft outcome, long-term outcome is not excellent. Do we bring them and open the right coronary artery? You probably from the gist, you know my practice. I usually don't do vein graft intervention except in acute MI, and this is why this lady is here. Any comment before I show you the angiogram and what?
We cannot see the video.
We don't know
Okay.
The segmental wall or viability and things like that.
Normal LV. She had a normal LV in September, about a few days ago. Yeah, okay. So because she came here on time and the vein graft was open and it was stented, and it was discussed with me. I said, fine, we'll bring her in so we could open her native artery. Because I know once the vein grafts start going, usually will go in no time, particularly in diabetics. She ended up with, again, a little bit undersized stent, 275 in a vein graft, which I think is a little small, but, and she had collaterals to the BDA from the OM through the vein graft and also from the lima.
Can we see
the
the
lima is
film?
connected. Yeah. So if we go forward.
Can we see the film?
Can we go to the? Okay. Here's the angiogram. Can you see the angiogram now? Can we?
No, we cannot see the angiogram. Yes, now,
Okay, here we
now
go.
we
Can you see it now? So this is in September, about 3 weeks ago. This vein graft to the OM was completely open with collaterals to the right. Obviously today, my plan was to go through this vein graft, open the PDA, then go through the vein graft to the right and open the LV branch and coil both grafts, if we, However, you could see the first shot here changed the whole plan because the vein graft between September and now has thrombosed. Can you see the thrombus in there?
Yeah.
Yeah. So anyway, we might go forward. All what I did, I just took an aspiration catheter, aspirated that. You could see it coming in up and down next. and the flow is established. However, there was two decent epicardial collata to the PDA, which I thought I could use instead of going through the lima, because it's a little less risky than go through the lima. But now we don't see anything, so the decision was made for me just to go now and open the LV branch and see if we could find where the PDA is. And if that's not the case, we could leave the PDA for the time being, sort the LV branch and the RCA, and then come back another time when the collatas could have matured a little bit more when this is open.
So you did just aspiration, or you?
Just aspiration, yes.
Just aspiration, yeah.
Absolutely, and the thing is, she was completely asymptomatic. Obviously, we've sedated her, give us some painkillers, but she was asymptomatic. This was the first shot, so this didn't happen overnight or here. So she came with this. So next one. So now the strategy changed. You could see that hardly any, because they use next one. I took a Corsair and a wire just to see if I could explore all the previous epicardial collata that I've seen before. You can see that there's no. One option would have been to take a guide liner down, so the injection is a little bit more forceful to see the collaterals, but I thought that's not the right thing to do at this stage. Next. You can see a tip injection from the microcatheter, and there is very small connection, but it's difficult to know the anatomy. And I think it becomes really dangerous if you're not doing, particularly with the epicardial collaterals. Next one. So now we revert back to going through the vein graft to the LV branch, opening that and then assessing the PDA after that. So, and here's the setup angiogram. Any comments how you'd approach this or what you would do?
Okay, so you have...
I suppose, sorry, before we go further, the question is, would anybody do what I did,
So-
bring the patient back and open it up, or would you accept the result of the vein graft?
So we'll use the vein graft now, retrograde.
Yes, well, I mean, that's open to comments and to hear what you guys think.
Yeah, well, I think the best way is through the graft, because it will be difficult to do anything about, from this, the collateral, the small one that you've shown us. But we haven't seen the injection you did. You did an injection there, and it was very tiny, or what was it?
Yes, very tiny. As I said, just between 3 weeks ago and now, the collateral has disappeared or kind of become immature because of the vein graft thrombosis and the poor runoff.
Okay. And the lima is working?
Any comments on this? Sorry?
The lima is okay, and all the other graft is...
The lima is okay, and there are some collaterals from the lima to the distal PDA, but as I said, for the lima quite tortuous, I thought it might cause a lot of ischemia, and I need to do that in a little bit more controlled manner, particularly if I do this. But yeah, so this is where we are, and this is the CTO that we have of the RCA. So a question in my mind for you guys, and to see how people will practice, would you do this? Would you bring the patient open the native? Or would you accept the vein graft result and say, when something happens, we could deal with it? And if you are going to do it, how would you approach this?
The point is that the graft is giving a small dystally in the PDA, so I think if we get a good achievement for the native, I think it will be more to relieve the ischemia or to much better, because this is an RCA is not small. What do you think?
I don't know, Mohanad. What do you think about medical treatment in this case? What's the harm of medical treatment here?
Well, I mean, there's no harm, clearly, but as I said, the lady presented with 2 MIs now. We know that this vein graft is degenerating, and I think you could see that the stents are underexpanded, and to my mind, very undersized. Because with vein graft, you hardly ever find a vein graft less than 3.5 or 4. So to have a 2.75 stent in there, even was dilated with a 3.0, is just not enough. And you know that down the road, I don't know, a month, a year or two, this vein graft will go. I have an easy conduit right now that I could open the native, and we know that the results from opening the native are much better than the vein graft intervention. Plus, acutely, the acute event and the acute complication are much less when you do native versus vein graft intervention.
Also, I think you have a good possibility
It was about being efficient, safe, and quick to avoid delay and to avoid X-ray and die. In this case, of course, I could try antegradely, but as I said, the proximal cap is quite ambiguous. Despite the occlusion being short, the proximal cap is ambiguous. I could spend a long time trying to go through it, and also I could cause problem because you're going to need a stiff wire to go through the cap. Osseal lesion, if you have collaterals, you go retrograde. If you have an occlusion that's more than 20 millimeter, and the distal vessel is not as good for dissection re-entry, retrograde approach is better. Again, with ambiguous cap, despite having some ways you could overcome this, I think quite often it's easier to do this. In this case, because it's a vein graft and it's stented, I think it's very safe to use it. And I could see it very easily. And navigating this, it may be a little tricky around it. You could see the tortuosity in the LV branch as well as in the crux of the RCA. But it is a safe approach and a very controlled one. And this is what I kind of did today. Now go forward. Yeah. So we went retrograde through the vein graft. I was going to do this all live, to be honest, but I thought because the question, again, the discussion after this, once you've opened the native, and I'd be interested to hear your views, guys in there, what would you do with the vein graft? Would you coil it? Would you leave it? Or what would you do with it? So you could have a think about this and tell me what people would think. So we went retrograde. You could see the Corsair XS, Corsair Pro XS. And the Corsair Pro XS is smaller than the Corsair Pro, but bigger than the Caravelle. So it gives you kind of the best of both worlds.
Okay. In retrograde, you usually use certain wires. But does it differ if it's from the vein graft? You use different wires or the same choices of Seon and so? What do you do?
Yeah, I mean, yeah, to access the vein graft and the native artery, it's a soft wire, basically. Because I could see where I need to go. Once I'm come to the body of the CTO, that's a different story. Then it becomes a wire escalation strategy. If I need to get a confianza to pierce the distal cab, if I need to use a Fielder XT to knuckle back, and if I need to use different wires. And that's what I did in here. I take a Fielder FC here with the Corsair. We managed to navigate into the distal RCA. You could see the severe tortuosity at the tip of the Corsair. I'll go back one also in this view. Go back.
There are some arguments about medical treatment, so can you bear with us for that, okay? You don't
sure. No, absolutely.
Yeah,
absolutely. I mean, it's a valid thing, and it's not. But as I said, to my mind, this is a young lady, 55, normal LV. She's had 2 previous MI, and she presented with a problem with the vein graft. To my mind, I thought a preemptive action, opening the native and sorting this out, is much better than waiting for something else to happen. But she's got high risk, and she will have another event. Do you guys not share this view, or?
Yeah, actually, she has a patent lima, and now
I need to show you the lima.
You open the graft.
The lima, yeah. That's true. It gives some collaterals to the PDA. Collaterals never give you the same perfusion. It's only 30% of pressure perfusion, and the patient will always be symptomatic. As again, at this age, I think it's probably worth doing this, but that's my view.
And you know, Mohamed, we were just discussing yesterday that retrograde approaches should be done by experts, because if you do a retrograde and you don't have enough experience, you might go into trouble.
2,000 Hepburn, please.
And I think with your experience, retrograde is a little bit, it's never easy, but I mean, it's more, the success rate will be higher if you have good experience. That's our advice.
Absolutely.
That's our advice to our CTO operators here in Egypt, that for retrograde procedures, you should have a help by a retrograde expert. So that's what we do here.
And also,
I think even even for the retrograde itself, it depends on what collateral you are using. The safest way for somebody who wants to start doing retrograde, a vein graft is really the safest and the easiest way to do it, because it kind of gives you a safety of the vein graft. It's very open wide, and you could see the conduit very well connected very well. And in the same token, you could practice, because it's how you handle the equipment, how you keep the Hepburn on board, how you manage to deliver the microcatheter and navigate your way through the tortuosity and so on. Then you come to the septal, which are still safe, but could have a problem by dissection or by perforation. Then the epicardials, obviously, which are really for expert and really have to be handled very, very carefully. Because if you have a problem with them, could be disastrous. And then you've got the lima. The lima is always difficult because of the tortuosity. Whatever you put through it, it will straighten out and become like almost the concertina effect, and ischemia will ensue. So these are the kind of the collata that you could use.
This is a very important advice, actually, for the antegrade operators. If you want to start retrograde, start by vein grafts first, and then start by septals. And if you have good experience, start epicardial.
Yeah, epicardial, I would leave it until you've done at least 100 retrograde, because they are quite very delicate and really. Yeah.
Mohanad, the problem of this vein graft, this graft is full of thrombi. As you do some aspiration, and this is patient with already, so it's...
well, this one doesn't have the thrombus. That was in the vein graft to the OM that I was going to use to as a retrograde approach to the PDA.
I mean, in general...
This one, yeah.
In general, when
you're right. I mean, when they are diseased, quite often they will have... my wire has come back now. Anyway, so we managed to do this. Then I came... sorry, go back. Back. Okay, so this is where I went with the Fielder FC wire. Then at this stage, I know we came to the distal cab and the body of the CTO. And my wire of choice here was a Gladius MG. It's hydrophilic. It's got a very soft, small tip, hydrophilic, and a very nice handling to navigate through the CTO. And if I need to knuckle, if it's not going anywhere, I could knuckle it. And it's very nice knuckle, and that's how it's got, the MG stands for micro gap. So
do you like the knuckle of Gladius, Mohanad? When
yes,
you're using it?
Yes, it's quite good, particularly in calcified arteries.
You like it better than Fielder XT, yeah?
Not necessarily. I still start with the Fielder XC, because the Fielder XC always gives you a little smaller space in the subintimal space, so you could handle it a little bit easier. But if it's not going, the Gladius MG is a very good choice, and that's why I chosen here. And we managed to navigate through the CTO easily. Next one.
Well, we were just discussing that knuckled wires are the Fielder XT and the Pilot. So can you tell us more about the Gladius? We don't really have experience with it.
Sure. Well, the Gladius is kind of the Asahi equivalent to Pilot 200. It's the same kind of tip load, about 4.2 gram. It's got the same design as all the Asahi with the 6 component inside. It's got the rod at the tip. It's very, very nice wire to handle through any CTO, to be honest. And with the MG called micro gap, so when you're trying to knuckle, you have no control where the knuckle will form, particularly with the Pilot 200. So the knuckle could be quite big. With the MG, where that micro gap happens, that's where the MG will bend and the knuckle will start. And also, it's very easy. If you take your time with it, you quite often you make some nice progress. As you can see here on the screen, we managed to navigate through this CTO easily.
Boston has innovated some new wires. Did you have experience with it? I mean...
no, I haven't. They are supposed to be coming to us. COVID has slowed everything down, so we haven't. Yeah, they've got the Hornet and they've got some Fighter, and I've used them. Actually, I think I was in Saudi Arabia doing some cases with them, and I used them, and they're very nice wires. The Hornet is 14 gram, which is a little bit more stiff than the Confianza. The knuckle, to be safe, I mean, you use the knuckle when you're not sure of the course of the artery, or if you're trying to get rid of the calcification, because that avoids the calcium going subintimally. So here we didn't have to do this, and we came across to the guiding catheter, and that's the MG. I'm going to try to. So one option, once we've got to the antegrade catheter, which here hopefully will. Okay, so you could do this, get it to the catheter, to the antegrade catheter, advance your microcatheter, and then take an externalization wire, which is the RG3. It's 330 centimeter. But I'm going to try to see if you could do a tip in. And the tip in technique here means that you take the antegrade catheter and you try to get the wire into it. And what you want to do is you need to put the catheter or the microcatheter on the bend, because intuitively and physically the wire will choose the bend. Do you think guide
extension can more easier than this tip-in?
Well, no, I mean, because the guide, I've got to the guide, that's not the problem. I don't think it'll be any different, to be honest. I'm going to give it 2 seconds. If not, we're going to take an RG3. So I save the time because I want to show you also how to use the coils. Yeah, this is not.
Dr. Mohammed, I can see that you are not using an amplat. You are using a right tool.
Well, no, we had the amblats first, to be honest. But when I came to take the wire out, the angulation of the amblats was not suitable, and I had a JR4 on the table, which was open at the beginning, so I took it because it's more coaxial, if you like. Yeah, I think this is going to be difficult, so I'm not going to spend too much time here. We'll take the RG3, please.
We sometimes deep throat the guiding and use it as a...
Yeah.
a
No, I mean, I've got no problem because my wire is in the guide. I'll just push it up now, and I'll take my retrograde Corsair back. That's what you could see now it's gone to the guide. I've got no problem there. Yeah. And we'll take the RG3. So take this wire away from me, please.
There has been a question in the previous session about wire trapment. After the RG300, you get it exteriorized. Then you trap the wire before pulling back the microcaster. Do you do that, or it's just you pull back the microcaster and that's it?
No, you don't need to trap anything, to be honest, because the RG3 is going around the heart and going around, so it's very fixed. You don't need to trap it.
Okay.
You don't need to trap it, and so basically now this is going to go around, and we'll show you how to take it out, so it's not. Here we go. It travels a long distance, obviously, so.
Dr. Hadi Abu Handish gave hello for you, and he would like to ask you, would you leave the Hadi Abu Handish? Yeah. Would you leave the saphenous vein graft, or would?
Well, this is the question I posed to you guys before.
To avoid using.
So once
lima.
you've opened the native, what would you do?
I would leave it, actually. It will take care. It will take care about itself and close soon, I believe.
Yeah, I mean, this is the controversial issue. This is why I chose this case. So to externalize, I take my introducer needle and put it in the TUI or the catch itself, right? And that makes it easier. And we keep pushing. Here's the wire.
The camera, please be near your hands.
Can you put it on my hand, please? Yeah.
Yeah, please.
Yeah, can you focus
on it? This is how to use the RG3 to externalize RG3.
Yeah. So we put the needle through the catch, and now the wire's out, and all what I need to do is just feed it through.
شايفين دي يا جماعه؟ اصل الواير ما بيخشش في الواي كونكتور كده عادي.
Put the light on for me.
بنعملها كلنا يعني.
Thank you.
مش حاجه غريبه.
So here's the wire now, and once we've got it through, I'll just push it a little bit more. And now we have an externalized wire. So now I could do all my procedure through this retrograde wire. However, often for me, I could move the camera back to me here. For me, often what I would do, because now I have a microcatheter antigrade, the worry about having a retrograde gear is, of course, the thrombosis or the native artery dissection or any of these problems. Of course, in vein graft is not a major deal. But if you're going through the left system, for instance, to do the right, once you've achieved the antigrade or the retrograde externalization, you could take your antigrade microcatheter and pass it through on top of the wire, and then becomes a normal antigrade procedure. I'm going to pull this back a little bit here so we could.
Yeah.
When pulling back, you disengage both, or just the? You don't disengage the guiding.
Well, again, because it's a vein graft, I'm not too. But of course, if it's a left system or the right system, you really have to engage the guide so it doesn't suck it back. Yes, and you always have to keep your microcatheter in the small channel so the wires, it's protected from the wire. Because any little movement on the wire could cheese cut through the arteries, and you could end up with a stenosis or perforation.
Yeah, it's a very nice.
So now we're externalized. Yeah.
Very nice demonstration how to externalize the RG3 and how to receive it from the other side.
So I'm just going to give a very small injection here antigradely. And you can see that, store that. You can see that the artery is open now.
Yeah.
So what I'm going to do is just take the Can I have a surgical scissor, please? Usually the wire stays straight. For this one, I have a little bend on it.
Do you routinely use IVUS and the this RCA, or what do you think?
We have the IVUS ready. I don't use IVUS very often, to be honest, but it'll be a good thing. We have time to show you the IVUS, maybe. I wanted to get this, I wanted to get this done, as I said, to show you because my plan is to coil this vein graft. I've done this most of the time, because I think the competitive flow kind of predisposes to possible thrombosis.
It's very good to see that you cut the tip of the RGC because it is
it's bent.
Yeah, destroyed, so it's easy
usually it doesn't, but for some reason here we had a lot of resistance and the wire got bent. Yeah, but if it is if it is bent in here, it's much easier to cut it, and you need a surgical scissors, so
it's a very soft to go in.
Yeah, so it's a sharp cut rather than having any little bends on the wire that will compromise your delivery of the microcatheter. So now all what I'm going to do, just deliver this microcatheter. And when you're doing that, when you come close to the both microcatheter, you really have to make sure
the manufacturers should do some innovation in this. I mean, they should do something about it, the RG300.
So here's the antegrade catheter. I said you need to keep them apart. So I am going to pull this back. In a smaller artery, they could interact, and the tip of the antegrade and the retrograde can become. Just going to push this wire on. Okay. So now I've got my wire Okay, and I'll bring this back a bit here. The vein graft. When you're doing this, before you take your retrograde wire and retrograde gear, what you need to do is to make sure that there's no injury to the collaterals. And that's what I'll show you what we need to do. So now I've got my antegrade wire and catheter where I want. So I'm going to pull the wire back. And we pull the wire back until, take this away from me. We need to leave it inside, but this doesn't apply much to the vein graft, but in principle, that's what you need to do. And I'll show you that in a second. Because you want to make sure before you take it out that the collaterals are not damaged. So we come to the soft part of the wire, which is going to be coming soon. And you leave it in the collateral. Then you take a cine to make sure you have no problem. Because if you have a problem and you may spend a long time to be able to, I'm getting some heart block here. Yes, she's quite ischemic. So we need to do this quick. Anyway, if there's a problem in the collaterals that with the wire out, you could run into trouble. Actually, I'm going to do this quick. I'll leave it for now. Okay. Because it's a vein graft for okay. Right. Okay. Can I have some atropine, please? Okay. I'll have a fielder FC.
The heart rate is slow,
just give
yeah?
You have some bradycardia.
Yeah. Bradycardia. So I'm going to just put the wire down and then move that microcatheter so the blood is flowing. And of course, sometimes that happens when you're taking your microcatheters out because you squeeze the heart and it becomes like a shoestring. Important to make sure that so we'll put this wire down and we'll move the guide catheter or microcatheter. So there's some blood flowing. Here we go.
What about the hemodynamics? The blood pressure is okay?
The blood pressure is, it's about 93. Okay. It was a little bit higher before, but okay. Store that. Can I have a 3.0 by 20 or 2.5 by 20 non-compliant balloon, please? So now it's a normal angioplasty.
Do you prefer to give some nitro or no?
We will, once I've dilated.
Okay.
And once I've done that, so we will give some nitrate, definitely.
The remaining issue would be the size of this, the site of stenting. I mean, where to stent.
Yes.
Yeah. This will be the problem.
This is a dynamic thing. So what we'll do once we've opened the artery, let us go, please. Ideally, we should try, but I'm going to go to 16, keep it at 16.
We have also distal lesion at the osteum, the PDA. So.
Absolutely, absolutely. I mean, to be honest, I don't know where the PDA is coming from. So we'll see now if we open it antegradally what will. Okay, here we go. I'm going to leave this in now. So we're I'll leave this out for the time being. Take this away from me. So now it's a normal angioplasty. We'll open it up and then we measure, see what size it is. I'll take the balloon. I usually dilate with a non-compliant balloon. So if you show me the cranial view roadmap, please, David. Heart rate has recovered now, the gear is out and the blood is flowing. So I mean that Mohammed here was supposed to be commentating with me, but he doesn't have his headset, unfortunately, because we missed getting another headset. We have 4, but I don't know where the rest has gone. So okay, let's go up there. 12, store 16, and down. So just do some gentle dilatation. I mean, I'm just going to give nitrate after and then assess what we have. You could see, can you see the hemodynamics?
Is okay?
Yeah, it's fine. She's recovered heart rate now, 78.
The heart rate went back to
170, 72. I think this is just the ischemia that we cause. I'm just going to try to do, okay, go up there. 16.
There is a question about a temporary wire before doing the procedure. Do you do that?
No. Come down. I mean, it's been more than, oh God, not with CTOs, rarely, ever. Even with the primaries, we rarely use rotablation, rarely use that. Store that.
It's diffuse
You can
disease.
see that we've got a decent artery here. It's going to be a large artery. And I think we're starting to see some flow in the PDA. Because I did think it was a functional. Go to cranial view. I'll give some nitrate and we'll take a picture. And then see what you think.
Can you give us another view? Maybe.
Yeah. So we've just gone to cranial, then we'll do. This was just a test. I'll give a proper angiogram. 500 nitro in. Just give it a couple of minutes to work. So, I mean, I suppose if I were there, I would be asking a show of hand who would coil the graft or who would leave it. Maybe you could do that for me, Amr or Adil. What do you think?
Okay, the question is who will leave the graft and who will close?
Unlock. Top and bottom comes in a notch.
مين يسيب الجرافت زي ما هو ما بيلعبش فيه؟ أنا شخصيا هسيب.
No, it's not this. No, it's not obvious.
طب مين عايز يقفل الجرافت ده؟ طيب a minority says to close the graft, but most say leave it.
Okay.
So what can you tell us? What's the pros and cons of this?
I mean, the cons are usually if the native artery, what you've done, for some reason you get acute stent thrombosis or anything, which is very unlikely. It's less than 1% if you size it and you deploy it properly and correctly. Another cons, I suppose, there isn't much to be honest. Go up. The pros is you avoid this competitive flow and the stagnation of the blood. So that's 16 and down. And then because you've got the native, you give the native the best possible chance to recover. And I said I've had a large series of these cases, not a large, but quite a few patients of these that we've kind of coiled the vein graft after, so you avoid the competitive flow completely.
I thought, Dr. Adil, that if we left the vein graft, mostly we encourage that stent thrombosis will be actually happening. The RCA is mostly diseased all through, so your procedure will be covering, I think, from most distal to most proximal. So when you leave the vein graft functioning, I think this is probably demand and competitive flows all through, and this is also could be a factor for after that stent thrombosis will be encouraged on. And also another factor, I thought that if we could know the real insertion site of the vein graft, could be another issue. If the vein graft is so distal and carrying the BDA, and I am going through that, I'll go to the BL branch and go to the RCA, I think at this time I could leave my vein graft, so it could be another opportunity that the BDA is a good supplier by the vein graft, and the BL and all through the RCA will be with the antegrade flow. If you don't mind, Dr.
Okay. So this is the cons, that if you leave the graft, you will have competitive flow, you have multiple stents in the right coronary, You might disturb the flow and cause thrombosis. This is the cons. The pros,
I think
you still have blood going to the distality. If something goes wrong to the right coronary, you still have a backup with the graft.
I think
I think I would never close a healthy graft. Why?
Yes,
I will leave.
because this.
That's not a healthy graft, remember? I mean, I could IVUS it for you if you want, and I bet you this is a 275 and a 445 graft, and it's already had a problem. So no question in my mind, and I've seen this many times before, that it will run into trouble.
But it's, the patient has
ring
already
down
passed.
For me, please?
How many years passed now since the RCA intervention? It's 6 years now since the last intervention in the graft, and it's still working.
Well, this is only about three weeks ago.
Cam, how much?
3 weeks ago.
3 years.
3 weeks.
3 years. 3 weeks.
Yeah.
3 weeks. Oh.
So now, yeah.
Oh, 3 weeks. Well.
So go back on for me. So this is the IVUS now. You can see this negative remodeling in the distal RCA. Just gonna get it to where we need to start. And we're gonna record. This distal is about 3, and I'm sure it'll grow to a little bit bigger, but for the time being, start recording, please. Can you see the IVUS?
Yes.
Yeah.
Okay, so we're just gonna pull back. You can see it's full of disease here, negatively remodeled. And as I thought, this artery is not gonna be less than 4, especially proximally. You didn't ring down, Sandra. You could see the subintimal, there's some subintimal space there, or hematoma probably, which we saw. And now we come into the proximal part.
This is 4 millimeters.
This is a big artery.
At least.
Yeah.
Absolutely. I don't recall putting a smaller than 4 stent in a right coronary artery for the last 5-6 years in here. Stop recording. Yeah, sorry, we asked for the ring down, but that didn't happen, but that's okay. Image is still acceptable. So go back on.
Can you revise the IVUS with us to tell us where to put the distal stent? Because we have to decide.
Sure. So can you see the angiogram? No, I will go to the angiogram in a minute.
Look for the IVUS.
Are you still seeing the IVUS here?
Yes. Can we shift?
Yeah, so can you stop that for a second? No, I just want to show you what the hematoma. So shift back to the angiogram for a second, please. Can you see the angiogram now? Yeah?
Okay.
Yeah, can you see it?
Yes, we do.
Yeah.
We see the
So if
angiogram.
you look around 9 o'clock, see that dye hole there?
Near the bifurcation, yeah?
Well, no, yes, just before the crux, before the bend.
Yeah.
Can you see the dye hold?
Yeah.
So
Because
if you go
this
to
one,
you
there's
can see
a
this is
lesion.
subintimal hematoma.
Yeah.
So you'll put
So
it
if you go back to the IVUS.
just before bifurcation, after this hematoma that appears distally, right?
Yes, definitely. So you could see there's a kind of normalish, if I call it normal. IVUS shows a lot of it. So go back with the IVUS, start from the beginning. Let's go back on the IVUS on the camera, please.
The anatomic rule is that the right coronary is the same diameter all through till the bifurcation.
Can you see the IVUS now?
Yeah, we see the distal now.
So it's negatively remodeled, it's underfilled, so it will grow, no question about this. We're going to come to the hematoma, which you'll see it about 3 to 6. Here you go, we're starting to see it, here you go. Can you see it from 12 to 6?
Yeah.
This is the hematoma we saw in there. And sometimes if there's no connection between the subintimal space and the true lumen, you put a stent in and it will baste it down. So sometimes treatment for this is a cutting balloon, just to cut the intima. I think in this case we will be okay. So I'm going to take a stent from the normal part of that, when it's reconstitute semi-normal, and we'll go back all the way.
It's a very nice demonstration.
Can I have a 3.0 by 33 Zions, please?
So you'll put nearly 3 stents, right? I mean, I think.
Yeah.
Yeah.
I said this will grow. I've got no doubt that it's going to be bigger, but because of the nature of the disease, we're just going to start with the 3.0. And Zions could go up to much higher pressure. It could go to 4.25 if we need to. Then the proximal part will.
So the IVUS is very important in this scenario, that because of this diffuse disease in the RCA, and it gives you how to use the size of the stent and also where to stop and where this hematoma, subintimal hematoma. So I think it's a very good demonstration for this are diffusely diseased RCA with IVUS.
Yeah, so this is the first stent, and we're going to take, can you give me a 3.5 by 38?
This is 3.5?
This is a 3.0 for the distal part.
Okay, so you can go higher if you want.
Yeah, I could go higher, just so I don't cause any perforation or anything. Because go back one for me. Are you back? Can you see the angiogram now, yeah?
Yeah.
Okay, so we're going to start from there. Can you put a little test there for
Can
me?
you go a little bit distal?
Distal.
Okay, just go up there. Go up there.
This is okay.
Yeah, I mean, we covered that area there.
Yeah.
But 8.
Yeah, this is very tight.
Yes, this is why it's underfilled distally. 10. In fact, I should make it a 4-0. Make it a 4-0, 38. Well, so you could still, we have an area that which we saw in the IVUS still, but we'll sort it out. Yeah,
Okay,
10.
open now. Open
it's
now.
expanded now. 12. And down. I'm only deploying at 12 to start with. Have a little test, and then it could go higher if we need to. So that. Okay. Oh, sorry, I didn't lift you. Okay. Go up again. 12. 16. Store and down. If you notice that we hardly take any cine during these CTOs, storing fluoro would do that same trick. You reduce your radiation by a huge amount of, and you save yourself radiation exposure as well as the staff and the patient. And you probably noticed that we have a, can you see this, it's called the rad pad again to protect me from the radiation coming from the scatter from the patient.
Co-pilot دايما مهم maybe.
Yeah. What do you think about the distal of the stent? Distal to the stent.
Sorry? We will assess it in a minute. I think it may need some more attention. However, you could see now it's grown up a lot, and I think this 3.0 will have to be expanded a little bit more.
You may need a stent, distal to the stent.
Sorry, I can't hear. Okay.
Okay.
Yes, overlapped. No, just a little bit further. Okay, go up there.
This is 3.05?
8. This is 4.0. 8.
4.0, okay.
Yeah. Yeah, we'll just deploy it slowly and at lower pressure. We could always go higher pressure if we need to, which we will, I suppose, in a minute. But okay. Store that for me. And down. As you saw, once you've swapped to an anti-grade approach, just with the same normal angioblast, really. That's there. Okay, go up there. Just want to see how long. I think we probably need a 28, 8, 10, 12. Store and down. Yes, coming back. It's all right. It's damaged, that wire.
It's very important what Mohammed is doing now is you don't advance the guiding except on the balloon, because if you advance it on the wire, you might cause problems.
Store that. Yeah, I'll have a 4.28 Zion Sierra, please.
Is 4.28?
Yeah. 28 is probably a little longer than needed, but I'd rather, because it's ostial area and the proximal RCA is always deceptive. You always need to go a little longer than you think you need.
So we'll be back to the distality after that, because there is something wrong.
Yes, once I've skewed everything proximally, I'm going to give some nitrate and take proper pictures and see what we are dealing with. And then we'll coil the vein graft. We still have 15 minutes, so we should be okay. Come on.
You have time, no problem. Please. We have time.
Because of our COVID arrangement, we're working in this lab, so yeah, 28. 23 would be a bit. So getting some of the, I think we have a hematoma distally, or maybe that's just an edge enhancement because the stent from the vein graft are coming on top of the artery. So we'll take a picture in a minute in the cranial view.
I think this is a hematoma, yeah, distal?
Distally, might well be. Might well be. I mean, I doubt it because if you see where it was before, it's gone. But let's see, we'll see in a minute.
So you will cover the proximal? Okay.
Yeah, I'm going to skewer the artery first, and then I will assess the distal part. Because sometimes with CTOs, most of the time, and you really have to have a strong discipline not to react to the angiographic appearance at the end of the procedure. The artery has been blocked for a while, it's underfilled, it's negatively remodeled, and any little disease could look really terrible. You ended up putting more stent than you need. So there's no harm in waiting and making sure, at least as long as the flow is normal, at least STEMI 3 and everything is good. Let me just get this artery in. Okay. So we've got that in the ostium. That's there. Come to LAO Kodo. Just want to make sure that we can get the ostium in there. More LAO. Just focus on the ostium for me. Unlock. Yeah, okay. Just 1 second. Okay, that's there. Okay, go up there. 12. So the ostial lesion, whatever, a little injection shows you where you are. Store that, go to LAO. 14, 16. And down. Here, because we're in the true lumen proximally, I could go to higher pressure. But I would say if I would have done this, for instance, as a reverse cut, or if there's a lot of subintimal hematoma, so that you really have to be careful how high you go, and because you don't want to cause perforation at the end. I think we could both dilate a little bit more distally. I'm happy with that.
We'll use a balloon for the distal?
8.
Okay.
Sorry?
So you will use a balloon distal? Okay. Or
yeah, this is the 4O stent. Go to 10.
14.
Store that. And down. I said, I think it's big enough, and it was a little negatively remodeled, but up again. 10. 12. Store that, and down. Because it's really crucial to make sure that you deploy your stent, you size it correctly, you deploy it correctly, because this is what will determine what we were discussing about. If you're going to coil the vein graft, you need to make sure that all done perfectly. Store that. Yeah, there's an appearance of dissection or something distally, which we'll take a picture and see.
Yes, there is a dissection.
We can see the posterolateral now. It was visible before. So what do you think?
Well, this is a very gentle injection, Hadil. I haven't.
Yeah.
I will show you a bit.
Because I think the wire went back. The wire went back a little bit. Yeah, I don't know why.
Also, what could be the reason for this is the blood running from the vein graft, because the vein graft is still patent, remember? So maybe that's a distal part. Go to cranial view for me, PA cranial. And that sometimes could be the reason. And this is why often the argument happens. And we know this because the native arteries block off and lock after vein graft because of the stagnation and here you go. See the competitive flow distally?
Yeah.
You can
and I think this is but we do have a dissection here.
IVUS will check the distal if you want.
Yes, I think it is very important to use IVUS to
yeah,
check
I mean, I can see the dissection. I'm just going to cover it so we don't lose that.
The problem is that you don't have enough wire length.
Let's go back
so try to advance the wire a little bit so we can.
Yeah, I'm going to try. Go back. No, forward. I will. It's come back. The wire tip is damaged, so it went to the small different branch. So can I have the talker on, please? Can you get me a fresh Fielder FC wire, please? Thank you. Now, I think we need to stent it because it was disease from the start. You know that. Little test centigrade, please. Yeah, this wire is damaged, so it's not going to take me where I want to go. It's okay. Good. No, it's going to the other branch. See, the tip is damaged, so I'll leave it there and I'll take... No, it needs to come to the...
Is better to use a balloon?
But this is a good lens for the IVUS. You can do the IVUS now if you want. I mean...
Yeah, okay. I'll do the IVUS. I just want to wire that main branch of the LV branch, if you like, where it's, and then we'll do that. Wait. Let me talk around. I'm going to put a bend on this one because they're similar color, so I don't want them to get mixed up. So we put a bend on the damaged wire and try this fresh one. Hopefully that will take me where I need to go. Of course, there's a chance of this going to subintimal space. That might have gone to the PDA here. Go back one. No, it's gone to that branch. Test them. Okay. Okay, good. That's enough. Good. Test. Okay. Where did that go? Right, we'll have the IBIS now. Let's have a look. So now I think this is the LV branch itself.
Yeah, okay.
And that's where we, if I go, I don't know if my guide, that's out. Okay, fine, that's all right. Okay, let's have the IBIS. I could see that even from the start, I thought we will need to go all the way down to that little branch. But we'll show the IBIS, we'll show the IBIS distally. And just for...
But we are not sure that you are in the same branch, right? I mean...
No, I am. And now I am. Before, I was in the smaller... If you see the... David, can you go back one for me, please? So where the competitive flow coming, so it goes horizontal toward about 4 o'clock. My first wire was in the top branch. Now it's gone to the main branch, which is, we saw the setup images. Can you ring down for me, please? Okay, ring down. Okay, good. You can see that even stand the 4.0 still looks a bit small, which is well deployed, and the cross-sectional area is big enough, but we'll try to get you. Here we go. We're now distal into that LV branch, still about 3 millimeter. Okay, so start recording.
What are your expectations? I expect hematoma. What do you expect? Dissection or hematoma?
Both the same, hematoma. You could see it there already.
So
yeah, can you see it from Agate?
Yeah, it's a
so I think what we could do, see the 3.0? I mean, that's expected, but I would rather post-dilate it now and not worry too much, because I know, and here's the 4.0.
So, yeah, 3. I thought that you would put 3.5. I thought that these stuff.
Yeah, the thing is with the right coronary artery is like a tube, and the diameter really doesn't change much until it bifurcates. So
4.0 is very good.
Whoever's doing CTOs or anything, yeah. If you see it at 4.0,
yeah.
But I said, for me, the eccentric, okay, stop recording. The eccentric calcium was the main thing for me to decide to go smaller branch. What we will do.
Who would put a distal stent, a fourth stent?
Majority wants to put a stent, Muhannad. What do you think?
I am going to put a stent, to be honest. Let's have the 2.5 balloon first. I will put a stent. I won't leave it because the exit or the distal runoff is what determines your long-term, even short-term outcome of the stent. If you don't have a TIMI-3 flow, especially when you have long segment stented, you know that it's going to be
especially you have a vein graft.
Yeah, because this is, but I'm hoping that we'll get rid of the vein graft so there's no competitive flow. And I will not do this until I'm sure the antegrade flow and the artery is well sorted and well treated. So there's a TIMI-3 flow and everything is just perfectly poised. So here we go. Taking the balloon and I'm going to dilate around the bend.
هل هنبص على النيو واير اللي احنا مشينا فيه؟ هل هنعمل فيه بري دايلاتيشن الاول ولا هنحط ستنت على الحته اللي كانت كفرد؟ يعني احنا دلوقتي في نيو واير فاست في، هل هنعمل بري دايلاتيشن في الحته دي الاول؟
It was a healthy area, so you can put directly a stent. You don't need pre-dilatation, I think.
أنا قصدي يا دكتور عادل بيه إن هو مشي بنيو واير في another ريمس، فهل دي هيطمن عليها الأول إنه يعمل بري دايلاتيشن ديستال ليها يشوف عشان يعرف إذا كانت هتبقى
Can you hear the question, Mohammed? There is a question now.
Yes, I can, and I think I'm okay. I'm in the right place. But what I will do is I'll re-engage my vein graft guide, and give you a retrograde approach just to everybody's happy that we are where we are. But that's absolutely important because you don't want to be deceptively thinking you've gone where you went and you're wrong. You're in the wrong artery. You end up with perforation and with problems. So just come to LAO for me. So I will show you that. Unlock.
This is very important to have a retrograde injection, through the vein graft.
The problem with the antegrade flow, you might not see properly.
Okay.
You have now antegrade flow. You might.
That's a big graft.
Go back to cranial view.
It's a very big graft.
Unlock.
Can it be away from the vertebrae because you cannot see from the catheter?
So there you go. So are everybody happy?
Okay. Yeah.
Yeah, so I mean, as I said, anatomically, that wouldn't have been anywhere else, but it's always important to make sure because you could, I'm just going to push this wire out a little bit more.
Where will you put your stent distally? I mean, this is the question.
Around the bend, around the bend.
Yeah. So a long one.
I don't think it's going to.
So you need a long one?
It's going to have to be, unfortunately.
Can you, the picture, because it's not seen from the catheters, can we go change the view slightly to see some angulation, right?
Oh, the angulation, right. Okay. Yeah, I'm sure we can, but I just want to get this wire a little bit more distal or to the vein graft itself, actually. Let's test retrograde, Ahmed, please. It's not. Okay. Yeah, I could see my control of the wire is really difficult with the severe. There you go, that's better.
Okay. I would really go after the bend with a longer stent.
Ready?
To go after the bend with a long stent that will cover the whole area.
Definitely. Just wanted to get this as a kind of fused balloon. So
the
go up there.
size.
You're just going to have to do it slowly.
The size of the stent. 3-0.
10, 12. Okay. 16 and down. Store that for me. Go up again. I need a fresh. Can you give me a fresh 2520 non-compliant balloon, please? And down. That's not. See if I could push. Maybe I should take this wire out actually because it's making life more difficult. Yeah, so go up there. 8, 10. Severe bend, really.
Yeah.
It's a 3 millimeter balloon?
No, this is 2.5.
2.5, okay.
But you notice, I mean, I tried to get that with the other wire in place. I could not advance this balloon, moving the wire. And this is something for the trainees. If you're in the bifurcation, you're struggling, go up there. 8, 10. You have to think about this and move your second wire. You find it works very, very well. Okay, and down. That does not bode well for, okay, that's fine. Therefore, taken, oops, did I pull the wire?
I think a guideliner would help here, I mean, because of the...
Okay, that's all right. My hands are sticky. Yes, this is having 2 hours. Okay, it's all right. Here we go. How long since the heparin, guys? Sorry? I'll give him another 2,000 heparin, yes, please. This is an antegrade normal angioplasty, so it's, test me there, antegrade. 2,000. Yes. Okay, store that.
You have time, Mohana, don't worry. So we...
okay.
We have time.
Okay,
we are not time restricted because of the prayers. We have time. We still have time.
Okay, good to know. That's. I'm going to take the stick.
So relax and. Okay.
Yeah, I thought. Yes, I just kind of. I said I wanted to show the kind of the technique for coiling because it's not something that, even when you have a perforation or something, to use the coil is quite an important thing to learn. Can you give me a fresh cyan blue wire test there? This wire is damaged also, so I'll have to. Okay, fine. Can you just give me a few degrees RAO, move the guides away? The guys are on top of the artery. Little, come. Okay, good. Let's have a little test. A little bit more to the right. Okay, fine. Stow that. It's interesting when you compare the angiogram with the IVUS. Obviously, angiographically, it doesn't look too bad at all, doesn't it? Does it?
Yeah.
But when you look at the IVUS, you know that there are areas that are not well deployed and still underexpanded, which means we will need some more work. But having seen this now, I think I'm really comfortable coiling that vein graft because I know we've
with
got
this
a very good result.
situation, who would just stent the ascending part of the branch before the bend, and who will extend the stent beyond the bend, because there will be a lot of difficulties in doing this. مين اللي يحط الستنت قبل البند؟
There'll be a long wire here. Can you have a cyan black handy?
اللي يحط بعد البند؟
Testing.
ماشي. ها؟ Okay. We have equal votes for stenting just before the bend and or after the bend. Sometimes you decide to stop when it's good to stop, you know.
Yes, absolutely. That's absolutely correct. Testing. I think this is becoming the subintimal space here. Yeah, I need a cyan black wire, please. That's enough. Cyan black. Yeah. Yes, the motto for this is we always say you have to use superior judgment so you don't have to use your superior skills. And sometimes stopping is much better than carrying on and causing more damage. Although in this case, I mean, we're in control. I don't think there's any problem here. The question becomes, do I need to go all the way around the bend? Probably not. Because you saw even the non-compliant balloon struggled. And I think there's no harm of just leaving it. We could do a DCB or just leave it to heal properly. But it's all valid options. We'll see. Okay, I'll take the tucker on. I'll take a cine, see where we are. Okay. Again, we still have a competitive flow from the vein graft, so the flow is not that great. See how severe that bend is?
Yeah, it is.
I think that's yeah. Go back one, show me where I am. Okay, so we just need to change. Just go back to that VA cranial for a second so I know the run of the artery. Test again. There we go. Yeah, I mean, I think that bend we probably will require. Don't forget, this is probably because of surgery. Because usually the fibrosis and manipulated the artery over there to be able to put the vein graft in. And I think you have a lot of fibrosis. We could take a guideliner, which I think is going to have to be done to get a stent down there. But what we'll do is let's have the fresh 2520 balloon, please. And if
so
we need to
use another balloon?
Yes, a fresh balloon.
Okay.
And if that doesn't work, I'll take a guideliner because I think it's important to establish good
So
flow.
your plan is to go beyond the bend, right?
I'm hoping to, but as I said, it looks like it's going to be a little difficult here. But if that's the case, we will use I will use a guideliner.
Or the guideliner to be sure that you will cross. Yeah.
If we have a problem in inducing the wire after the dissection, can we do it from the saphenous vein?
To start retrograde again?
Absolutely agree. I mean, that would be my second approach in here. I stent it through the saphenous vein graft. But I think it would be okay. So if I can advance it antegradely, I still have the retrograde gear in. So I'll just advance my wire and my stent retrogradely, overlap it to the antegrade. Let's hope this will turn around this severe bend. Oh, it's gone on the other wire. Okay. So how long since the heparin, guys? Just give it to Salah. Okay.
Okay. You have time, no problem.
Okay. No, I'm just thinking also for the heparin, that's something really important. Our nursing staff are really excellent, and the team, the cath lab team, they've got used to this every half an hour. Even normal cases now we get reminded, it's been half an hour since heparin or an hour since heparin. So that doesn't get forgotten in the, when you're...
Definitely the lessons from this case after CTO, not the problem to solve the CTO, the problem is to restore the flow with a good flow distally, and I think this is one of the important tips and tricks in this case.
Up there. So here we go, the fresh balloon has gone nicely, so go to 8.
Yeah, you have a tight lesion here.
Store, and down.
How long is this balloon?
Yeah, I mean, this is a 20. Go up again.
20.
It's
So
really, long lesion here, but...
so you need a very long stent, right?
Store,
And it will be
and
too
down.
difficult to, with a long stent without a guideliner, to cross this bend.
Yeah, I think you're probably right. So
I think you
one option would be, I have a balloon here. I could use an anchor balloon. I've got 7 French, so I could anchor the balloon distally and deliver my stent on the second wire. But
I think,
a guideliner would be much
Mohammed, that
easier.
the distal RCA is seen from the graph from the first injection that it's a very diseased
So
segment.
look at that now, guys.
Yeah, much
Can you see
better
that?
now. Yeah.
Now we've
very
treated
nice.
the native artery and it's wide open. The vein graft filled back from the native. And this is why you coil it. Right, okay, just, we need length. Can you give me a 3/0 by 20 or 33 Zion Sierra and a guideliner, please?
Okay, so this
I'm
is
going to use a guideliner up front so I don't have to be struggling with this, delivering anything here.
This
No,
will
6
be
French will do.
a good test for the Giants, if it crosses without a guideline.
a good test for Zions.
Yes, yeah. No, 33. 33. Yeah, I said there are multiple techniques here we could use. Sometimes in cases like this, I use a body balloon rather than an anchor, just by putting the
A second
balloon
wire.
next to the...
But you have to have 2 wires, and in this case, having a second wire
Yes, we
is-
might have to take, we might have to take one of them because it's a 6 French guideline. I'll take that. Thank you.
the guideliner.
Yeah. Yeah, I've taken a guideliner. So, 033. That's just to go around the bend in the LV branch.
Muhammad with you if you want, because he's younger.
Yeah. Hence the light.
Mohammed, do you push the guideliner over the balloon or just on the wire?
On the wire often, but you could see that I put the stent also at the same time. So that will make it much easier to deliver both the stent and the guideliner. And I'm holding them now together, and then I'll push them through.
Okay.
So that's kind of a nice trick too, because the guideliner sometimes, I took a 6 French on purpose so I don't have to be struggling through it. So you can see the guideliner has arrived before the stent. Now, if I'm struggling, I'll just push the stent through. I'm just going to wash my hands in here. Just let the wire go, please. And I'm just going to push this down a bit so we're really secure in where we are. It's taken all the branches now, but there we go.
The distal, yeah, this is much better. Still have resistance?
Okay.
Yes, so I'm going to advance the guideliner on top. Hopefully this will go. I'm going to take the other wire out because there's no need for it anymore.
Remove the other
It's
one.
just hindering. Take that away. Okay. So now if the guideliner does not advance, then here's the Zions, and
All
it's
right.
come nice.
Yeah.
Let's go back one. Go back one. No, just forward. Okay, just to see where I'm going to put my stent. Okay. Little test centigrade.
Yes,
I think
Yeah,
is
this is
perfect.
good. I mean,
This is a good
Yeah,
position.
test.
But you
yeah.
will need a second stent.
Yes, I think so, which is
Yeah,
fine. Okay, let's go up there.
Can
Okay,
you have
go up.
from the vein graft test?
Yeah, we can. Just one second. So I do want the vein graft test, which is fine. I think it's just anatomically. Here we go.
All right.
Store that. I could come back a notch.
I think you can advance if
That's
you...
okay. Just go up. No, I don't want it because it looks all right from there. Just go
Okay.
to 8 atmospheres. Some people do stent across the vein graft, but because I'm coiling it, I'm not going to be store that. I'm not going to be too fussed about it. Yours 10, 10, and down. Can you get a bro-grade catheter, please? Go up again. 12. Store down. Yes. I mean, sometimes for the vein graft, I use the vascular plugs, which are, okay, little test name, which are much easier to but store.
Yeah, great.
Yeah, so we
still
still
need
have
a-
one more stent to put in between.
You still
these
need
two,
a
and then
stent in between.
We'll go to coil. We'll go
There
to
is a
coil the
stent
vein
missing.
graft.
There is still a stent needed.
Yeah, come to LAO.
ايوه لا لسه لا انا قصدي ان هو خلاص كفر
Okay. Store that. Can I have a 3-0 by, actually, I need to take a cine. I can't see very well here.
اه الصورة
Yeah, 3-0 by 38.
38 will be very
See the
long.
hematoma?
Ah.
Yeah, I think it's maybe, well, actually, it's too long, actually. 33 will do. 3 or
33
33,
is
sorry.
okay.
Yeah, you could see the hematoma or the dissection
Yeah,
that was
yeah.
caused from before.
Yeah.
It's,
Okay.
because I think, Mohanad, this from the first angio that this part is diffusely diseased from the start. So
Yes, yeah, absolutely.
We
I mean, to be
know-
honest, this was my plan. I knew that we were going to put stents all the way down there, that way. My plan, this was, I wanted to open the PDA first, but it's,
difficult, yeah.
because of the occlusion of the vein graft to the OM, that changed my approach because I couldn't do that anymore. So I'll leave that to mature and for the RT to settle down, and then we could always come back if she's symptomatic. If not, I don't think we need to be doing anything. So I'm
But
just
anyhow, we are
focusing
now
on it.
more relaxed and just needing one stent to finish the job, right? I mean,
Yeah. Can you put your hand by your side for me? Is that her hand on the side? Can I have the talker? Yeah. Yeah, please, thank you. Okay. Okay, good. That's okay. Thanks, Rebecca. Thank you. It's going out of test me there. Is that test on the retrograde? Okay, here we go. That's fine. Okay. Just preempting. Okay. All right. Is that the stent? Okay. Let's go back one for me, David. Good. Yeah, I mean, as Amr mentioned, these cases really, at the end, is sorting out the whole. You go across the CTO and you think, well, hey, we finished here, we're very good. But there's a lot of disease, a lot of work to be done. And yeah, it takes a bit of time to get that sorted out. Let's go back one again. Let's make sure that we're overlapped. Okay, little test there. I think we're overlapped well. Yeah, okay. Go up there. 8, 10, 12. Store. And down. Let's bring it back a bit. Let's just see. So 12 atmosphere should give us enough. 3 or 3.2, and then we'll. Okay, good. Store that. So just a little test. I know the balloon unfolded. We're still there, but okay. Go up there. 12.
Fantastic result, Mohammed. It's a very
14, 16. Store, down. Okay, so I think this is okay. I could kind of optimize it a little later. I'll do an IVUS in a second, but we'll take the prograde and take some coil and do the vein graft.
Maybe we'll have a minute to discuss the Newcastle deal, Newcastle deal, right?
Have you any shares with it, Adel? Have you bought any shares in it? Yes, it's quite good. Everybody is buzzing here because it's going to make it's going to make the town more, which is good. Okay, let's have the prograde catheter. So when you're coiling, this prograde catheter is an old one actually, but it's come with a hydrophilic, really slippery stellate, and it says 3.2 French, the catheter itself. So we're going to flush it, and it depends on what you're coiling. So in cases where you have a perforation, you need to position your catheter really where you want it, because if the coil comes out in the wrong place, you could end up with more problem than
What is the size of this?
solve it. Yeah, this is almost the same as the fine cross, but the lumen is a little bit bigger because this one is slightly thicker than the fine cross. So this we use it because I use the Boston Vortex coil. Now there are some more coils on the market right now that are, if you wanted to use them through the microcatheters such as Corsair or Refine Cross, there's the neuro coils.
This is you need a bigger coils, yeah?
Yeah, and here we're going to use, because there are stand, I could use hairy, bigger coils. I'm not too worried about it. Fix that for me so it doesn't advance.
So,
and the question also becomes, where do you put the coil? And
you
we'll
use
try to...
Boston or EV3?
Sorry?
What type of coil do you use now?
I'll show you. I mean, we have what I use usually is Vortex coil.
Okay.
And these are from Boston. You're absolutely correct. So let's take this wire out. So if you're coiling an aneurysm, basically you take the coil, you put it in here, and there's a 3 ml lower lock syringe, and you just inject hard, and the coil will just fly into the aneurysm.
Yeah, this is a problem.
In here is a little different because you have to be control of where you're going to put your coils. And what you will notice that the flow will not stop immediately. And 1 or 2 coils are not enough. Sometimes you have to use 2 or 3 or 4 coils just to block the whole artery. This is where some people think the valvular block is a little bit better, but I thought, okay, can I see what coils...
But is there a risk of coil migration, for example? I mean...
Yeah, exactly. But this is why you have to be very careful where you deploy it. In this case, with the presence of the stent and the size of the vein graft, I think we're okay. But if you're coiling a perforation in the coronary artery, you really have to be precise where you deliver your... And this is where the stellate comes in. Because you take the coil with the stellate and it'll...
So you put the coils at the stent, the graft stent, yeah? On the stent
yes,
in the graft.
I'm going to go to the horizontal part of the artery. Can I see what do we have here? Turn it around. Turn it around. So do we have any hairy coils? Yes. So the hairy coils kind of promote thrombosis quicker.
هو هيقفل بالستنت جرافت ولا بالكويل؟
الفين جرافت.
الفين جرافت.
الفين جرافت.
I'll take this one. Yeah. What's the other one? Show me the 4x3. The 4x. Turn it around. Turn it around. Yeah, I'll take this one first, and then I'll take the other one. So of course the coils are nitinol, right? And when you they come as a line. Just and I'll show that to you. Yeah, 4x4. Okay, can you show me the box? Can you just can you bring the box? No, the box. Yeah, just bring it here. Can I show you the box in here? Come across. So, can you put the camera? Move back, Muhammad. Move back a bit. Just put the. So can you see the box? Yeah. So when it comes out, it's usually a long wire now, but when it comes out, it'll be...
The wire is 018, huh?
Yeah, but it becomes like a coil. You can see the shape of it. Yeah. That's how it constitutes in the artery. Okay. So now this is how it comes. It comes in this little... So I'm taking this out. It comes in this needle, and you could see it there.
Yeah.
You see the coil?
Yes, we saw the
So basically, I'm going to introduce it to the micro catheter. There's a pusher here.
Okay.
We'll just push it in. Now it's inside the microcatheter.
Okay.
As I said, if you're coiling a, I'll take the stilet. If you're coiling an aneurysm, you just take some, saline and inject
You will
hard.
push it was 018 wire? Oh.
Sorry?
What wire do you push now?
The stilet that comes with the machine itself, the catheter itself.
Okay.
It's a very slippery stilet.
This wire pushes the
Yeah.
coil.
So this
the
stilet
coil.
will push the coil inside.
This one was used in the neuro intervention.
Not this one. No, this one is big. So the neuro intervention, that's why I was saying, they are very thin coils, so you could use the microcatheter. If you're down with the fine cross or with the Corsair, the neuro thin coil can be used through that. With these kind of coil, the Vortex, they don't. Because I said this, so you see it coming through the catheter in a second.
We want to see the angio.
This is like
There you go.
the,
So can you see the angio, yeah?
No.
No.
Yeah, now we see
Okay,
the
can you
angio.
put the angio on, please?
Yeah.
Yeah. So you could see the coil coming through, and I'm pushing it. And I'm just going to push it a little bit quick here, so when it comes out, see how it's shaped itself?
Yeah.
Yeah. So as I said, this will need 2 or 3 coils at least. I'm going to take a bigger one, take the 6x6. And I need to see if there's a hairy coil, will reduce the number of coils I need to use.
Yeah. This is what coils is used also for the aneurysm if you have an aneurysm.
Yes.
Yeah.
Absolutely.
Or you want to close
So
a
this is a
branch.
little
the
bit
point
bigger
is
coil here.
don't inject now
This is
before
6
you're
by
putting
6.
a second, because if you inject, you might
It-
migrate. So put a
It
second.
will not, this will
coil.
not migrate because we have a small
will not
stent in
migrate
there.
because
But in
it's,
normal circumstances, if it is somewhere else in the coronary, it can. And also how you deploy it. Let's have the stilet again. I mean, in this case now, because there's a coil sitting there, I could inject this quickly, but I'm not going to do this yet. Maybe the second, third, or fourth one we could inject.
Yeah,
them
that's
with
what I'm saying is
saline.
that you wait for at least two coils before you start injections.
Yes, absolutely. I mean, if you, to be honest, in this case, I might just deliver them all with the stilet. So, and the flow does not stop immediately, incidentally. Don't expect this. So I'm going to bring this back just a nudge. Okay, so just come through here. This is a little bit bigger coil. And you could see it coming through. You could see a little longer, I'm just going to push this quick. Here we go.
Oh, yeah.
So, yeah, so.
Did you see the push of the other one?
Yes, yeah. Because the
It's
other one is a
recorded.
bit smaller than expected. So I'm going to have a look and see if you have a hairy coil. What I could do now, I could advance my microcatheter or the Brograde beyond the first one to just jam them together
You
and
want
deliver
to
the
stack
third one
it
in
together.
between.
Yeah.
We have no, there should be some hairy coils here. Let me see. What do we have?
So we have 5 minutes to go, Mohammed.
Okay, yes, yeah. We're almost finished here. Turn it around.
Because it's time.
No, I'll take the 6.
Size is
just
4
2
by
minutes and
4,
we'll be done in here.
6 by 6,
And I'll do a
8
live
by
of
8
the
or like-
RCA and then we'll be done.
Congratulations for this great case, and it's fantastic, Mohammed. And I think we learned a lot how to close a vein graft also, and a very good retrograde case, and how to use the vein graft as a conduit for the intervention. And the decision to open the native vessel definitely is much better than the vein graft, the degenerated vein graft. And I think the total arterial revascularization must be done nowadays for surgery, because you know that the vein grafted life is not so good.
Absolutely. I mean, if any message I want to get across is this. Yeah, you could do a vein graft angioplasty, and some of them will survive, but we know up to 20% they will have an event sooner or later, and the vein graft will deteriorate. So my approach is the minute I know that the vein graft is starting to deteriorate, if you can get your native artery.
So if you have a choice, then do the native rather than the graft.
Absolutely. And to be honest, even if you send it to somebody who could do it, if you don't want to do it and you're not. So I'm trying to push this inside. I'm going to put one more coil.
I think now the position is good for the guy.
This is the time for injection before you leave. It's very important.
One thing, yeah,
It's
it's
very
not going to
important
be
that
blocked.
you,
This doesn't, yeah.
that
does
you
not,
see that
this
Mohammed
does
is
not
very
block
cool,
immediately.
very quiet.
This will take a little bit of time to kind of another one, please.
I think another one.
Another coil. Yeah, and I said I'm not expecting it to block immediately. It takes sometimes up to 2 hours, and sometimes a day or two. It's not a problem. But
At
it will
least
block
they
sooner
are
or
stable
later.
where they are. I mean, they are not moving. So
No, they won't. I said the issue for me never been about movement because of the stent. And also in diseased vein graft, to be honest, they will stick, they will not move, but it's something you have to be concerned about when you're delivering them. And hence the controlled delivery with the stilette. I could show you that we could do this with the injection, but I think it's not, it doesn't. You just take a 3 ml lower lock syringe that comes with the catheter itself, and you just fill it with saline and inject as hard as you can, like when you're doing the IMR or CMR. So here we go.
We sometimes use these coils to occlude branches from the lemur. Sometimes they cause.
Yeah.
Take care, because one
slipped down. Yeah.
Yes, it has. That's the first one. So they are a bit smaller. I'm looking for the bigger one, but to be honest, I think we'll just leave it. We'll take a little test here. It's not going to block off immediately. It will take.
I think you don't want to block now. I think you can wait for some time, because it will definitely
Store
close.
that.
So
yeah,
no need
I
to
wanted to put a hairy coil, which are really very good in promoting the thrombosis quicker, but store that. We'll do an IVUS here, and we'll just
nice,
show you
RC.
the IVUS, and we'll be done. Because I think we need some more optimization of this. Of this
okay, Mohammed, we'll have to leave you now, and thank you very much for the excellent.
Congratulations.
Thank
and
you,
we are
guys.
waiting
I will
for
see you. I think I'm due to
we'll
give
see you
the talk
tonight
at 12 o'clock,
after.
isn't it, or?
Yeah, we'll see you now in
I'll
another
see you a little
lecture.
later.
Thank
We'll
you.
meet again
Pray
in the
for us
afternoon.
then,
Okay?
when you're going for the prayer.
Thank you for your support and cooperation, Mohammed. Thank you.
Thank you, guys.
Thank you for
Thank you
your
very much.
colleague, Mohammed. Thank you.
Thank you, Mohammed. Ya Masraoui.